Usually when we talk about a medical diagnosis, there's this comforting expectation of precision, you know?
Right, yeah, like it's a math problem.
Yeah, exactly. It feels like engineering. You
Yeah.
break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is.
It's very binary. It's either broken or not broken, which gives us a clear target. And we naturally gravitate towards that in medicine. We like things to be, visible and neatly
We
categorized.
do. But what happens when the rules of physics inside your body they suddenly break down?
Mm.
Because your cells are physically changing shape.
Yeah, that's when things get complicated.
Really complicated. Today, we're looking at a bizarre reality where that diagnostic x-ray machine is utterly useless. We're diving into the microscopic, often really muddy world of cellular biology.
Yeah.
And we have a wild stack of sources to guide us on this deep dive for you today.
It really is a wild mix.
Right, we're pulling from A-level physics revision notes, some Khan Academy lectures, and these incredibly dense medical journals covering everything from gastroenterology to nasal inflammation.
It's a massive spread of information. I mean, we're ranging from basic math to advanced pathology here, but it all funnels down to the singular vital mechanism inside your body.
Which brings us to the actual mission for today's deep dive. We are laser focused on a highly specific, but honestly, universally critical question.
Mm-hmm.
How does the physical thickness of our cellular linings, what we call the epithelial layer, directly dictate how drugs and molecules pass into our bodies? Especially, and this is the key part, when those tissues are actively shrinking or atrophying.
Yeah, and at first glance, worrying about the microscopic thickness of a cell layer sounds, I don't know, incredibly niche.
Like, who cares, right?
Exactly. But the implications of this question affect virtually every medication you have ever taken or, will ever take in the future.
So by the time we're done today, you are going to see a massive collision between basic high school physics and the chaotic reality of human disease.
It's fascinating. Because to understand how a drug crosses your cellular barriers when your body is in a state of illness or atrophy, we actually have to step outside of biology for a moment.
Wait, really? Outside of biology?
Yeah, we need to start with the fundamental laws of physics, the rules that govern how any molecule crosses any barrier, anywhere in the universe.
Okay, let's unpack this. Because when we talk about physics and barriers, we inevitably run into a guy named Adolf Fick.
Ah, yes, 1855.
Right. Back in 1855, Fick posited what is now known as Fick's first law of diffusion.
And it still holds up beautifully today. Basically, Fick described in strict mathematical terms how particles move from an area of high concentration to an area of low concentration.
Just the universal rule of things spreading out.
Exactly. It's how the universe tries to find balance.
The Khan Academy lecture in our stack actually does a brilliant job of visualizing this math. Like, imagine you're a scientist trying to maximize the rate of particles moving across a barrier. The video outlines 4 fundamental ways to speed that process up.
Right. 4 distinct variables.
Yeah. So first, you use smaller molecules. They have a lower molecular weight, so they just physically move faster. Second, you increase the pressure or the concentration of the molecules on one side of the barrier. Third, you increase the total surface area of the barrier itself, which just gives the molecules more physical space to cross.
And the fourth way, which is the absolute anchor for our discussion today, is to have a thinner wall or membrane.
A thinner wall. And if you look at the A-level physics revision notes, the math lays this out in black and white. The equation states that the rate of diffusion is proportional to the surface area multiplied by the concentration difference, and then all of that is divided by the thickness of the membrane.
Which is the crucial part.
Right, because thickness sits in the denominator of that equation. The relationship is a direct inverse. So if the diffusion pathway, like the actual physical thickness of the wall, if that halves, the rate of diffusion doubles.
It's elegant, it's predictable, and entirely mathematical.
Let's bring this out of the textbook for a second, just to make it real. Think of Fick's law, like trying to escape a crowded indoor concert venue when the show ends.
I love this analogy.
It works, right?
Yeah.
You're going to get out of that building much faster if the crowd is small, that's your low molecular weight. You'll get out faster if the crowd pushes harder toward the exit that's high concentration. You'll escape faster if the exit doors are incredibly wide, large surface area. Or, finally, you'll get out much faster if the hallway leading from the concert floor to the exit door is incredibly short. That short hallway is your thin membrane.
What's fascinating here is that while your concert analogy and Fick's equation perfectly describe a simple inert barrier, Biology is notoriously messy. It absolutely refuses to be that simple.
How so?
Well, we can't just assume that because a biological wall is thin, a drug will automatically rush through it in a predictable way.
But doesn't the math demand it? Like, if the hallway is shorter, Fick's law says the crowd gets out faster. Period.
The math demands it for a uniform barrier. But human tissue is constantly throwing up roadblocks. Let's look at human skin, for example.
Okay.
Our sources reference this pivotal study by Elias and colleagues from 1981. They were looking at human skin penetration, trying to apply Fick's law to see how fast chemicals would absorb based on the thickness of the skin.
So they expected thinner skin to equal faster absorption.
Exactly. But they found that absorption did not correlate directly with skin thickness at all, nor did it correlate with the sheer number of cell layers.
Wait, so Fick's law just completely failed on the surface of our bodies?
It was overshadowed by biological complexity. In the skin, they discovered that intercellular lipids, which are these specific heavy fats packed tightly between the skin cells, they were dictating the absorption rate. Yeah, the skin is uniquely designed by evolution to be a suit of armor keeping the outside world out. So it breaks Fick's most basic rule by piling on these complex, fatty barricades. You could have a very thin layer of skin, but if it is packed with those dense lipids, the drug still won't get through.
Which means if we really want to see Fick's law interacting directly with tissue thickness, we have to look past the skin.
We do.
We have to go deeper inside the body where those heavy, fatty barricades just don't exist.
We have to move to the wet internal surfaces of the body. We need to navigate the mucosal membranes. Because here, on the inside linings of your organs, the thickness of the epithelial cell layer plays a profoundly direct role in drug absorption.
Okay, so let's map out what these internal borders actually look like. When we say mucosal barrier, we're talking about the tissues lining your mouth, your gut, your nasal passages. And our sources emphasize that this isn't a static wall. It's a highly dynamic, viscoelastic gel barrier.
It's constantly shifting. It's made primarily of water and mucins, which are these high molecular weight glycoproteins that tangle together like a microscopic sticky fishing net.
A sticky net.
Yeah, and this net is constantly secreting new material and shedding old material.
So beneath that sticky mucus net, you finally hit the actual cellular structure. The outermost layer is called the stratified squamous epithelium.
Which is a mouthful.
It really is. For those of us without a medical degree, just picture tightly packed flat cells stacked on top of each other like pancakes.
Perfect visual.
So this stack of pancakes is the main physical barrier to drug diffusion. Below the pancakes sits the basement membrane, and below that is the submucosa, which is highly vascularized.
Right, it's packed with blood vessels.
Exactly. That submucosa is the highway. It's where all the blood vessels are waiting to sweep the absorbed drug away into your systemic circulation.
And when a drug, say an allergy pill or a nutrient, arrives at that outermost pancake layer of epithelial cells, it essentially has two main routes it can take to cross over into the bloodstream. The first is the transcellular route.
And this is where the drug goes directly through the cell itself, correct? Like it passes straight through the cell's top membrane, travels through the interior, and exits out the bottom.
That's the one. But the second route, which becomes incredibly important when we talk about disease, is the paracellular route. This is where the drug bypasses the interior of the cells completely and instead squeezes through the microscopic spaces between the adjacent cells.
Okay, let me try another analogy here, focusing on the mechanics of that. If the mucosal lining is a wall made of porous sponges, the transcellular route is like a drop of ink soaking directly through the body of the sponge itself. While the paracellular route is like water trickling down, finding the physical cracks and seams between the individual sponges.
That is a much better way to visualize it than a solid brick wall because these cells are permeable. But we have to understand that the seams between your sponges are not just open, empty space.
They aren't.
No. The cells are held together by tight junctions, which act as highly regulated microscopic gates. And within this paracellular route, the space between the cells, there are two distinct pathways.
The sources get wonderfully specific here. They divide it into the pore pathway and the leak pathway.
Right, so the pore pathway is your strict bouncer. It's highly selective, regulated by specific proteins called claudins. It only allows tiny ions and very specific small molecules to pass through, and it judges them based on their exact size and electrical charge.
But the leak pathway operates by completely different rules.
Very different. The leak pathway allows much larger molecules, macromolecules, to cross the barrier. And rather than being a passive sieve, it's regulated by the cell's internal skeleton, the cytoskeleton, and specifically by a protein called MLCK1.
I was looking at that acronym in the notes, and instead of getting bogged down in the chemistry, it helped me to think of MLCK1 as a microscopic pulley system inside the cell.
I like that.
Like when it gets activated, it physically yanks on the internal skeleton of the cell, pulling those tight junctions open to create a larger physical crack between the sponges.
That mechanical pulling is exactly what happens. And both the sponges themselves, the cells, and the pulley systems regulating the gaps are entirely dependent on the structural health of the tissue. If the cells are healthy and standing tall, this barrier works perfectly to filter what gets into your blood.
But what happens when those cells get sick?
And this brings us to the real heart of the deep dive. We now know how drugs cross healthy, tall cells. But what happens to the physics and the biology when these tissues undergo what the literature calls active atrophy?
Right, active atrophy.
Atrophy is a state of cellular wasting. When tissues are starved of nutrients, deprived of hormones, or subjected to chronic, punishing inflammation, they physically change their architecture. They shrink, and the entire tissue layer loses its thickness.
The physical measurements in the sources really ground this reality. I was reading a 1994 study by Taba and colleagues that looked specifically at enterocyte dimensions, the cells lining your gut. They found that a normal healthy gut cell stands about 30.7 micrometers tall. But in patients dealing with abnormal sugar permeability, which is what we commonly call a leaky gut, those cells physically shrink down to 25.5 micrometers.
And it progresses even further. In patients with severe celiac disease, where the body's immune system actively attacks the gut lining, those same cells atrophy all the way down to 19.5 micrometers.
That is over a third of the cell's physical height just gone.
It's drastic.
And the biological cost of this shrinkage is massive. The study notes that this diminished cell height reflects profound cellular immaturity. The brush border, which you can picture as a shaggy, microscopic carpet on top of the cell that grabs nutrients, it's totally underdeveloped. The cell just forgets how to do its job.
We see this architectural collapse across entirely different systems, too. Consider atrophic rhinitis, a condition affecting the mucosal lining of the nose. One of our sources details how progressive inflammation causes the healthy, tall columnar cells, which have these tiny hairs called cilia, to sweep away debris to flatten out completely.
They just collapse.
Yeah, they turn into squamous, pancake-like cells.
And the cilia are lost, meaning the nose can't clear out dust or bacteria anymore, and the mucosal glands that produce moisture literally vanish. The tissue just flattens out and turns into a dry wasteland.
The molecular mechanics driving this are fascinating. There's a study on a specific enzyme called TTL tubulin tyrosine ligase. Think of TTL as the scaffolding manager for the cell.
Okay, scaffolding manager.
The research showed that when TTL is removed, epithelial cells immediately lose their elongated, healthy shape. Without their scaffolding manager, they just stretch out flat at their base, completely altering the physical thickness and morphology of the entire tissue layer.
Okay, here's where it gets really interesting, and I actually have to push back a bit based on everything we discussed earlier.
Oh, okay.
Yeah, I'm listening to this description of shrinking, flattening cells, and I'm thinking straight back to Adolf Fick in 1855. Fick's law dictates that a thinner barrier means a faster rate of diffusion. So, if a patient has a highly atrophied, flattened cell layer, wouldn't that actually make it incredibly easy and highly efficient to deliver a drug across the mucosa?
That's a great point.
Right, because the hallway to the exit just got microscopic. It seems like drug delivery should be amazing in an atrophied tissue.
It is a totally logical conclusion based on the math, and it represents the great paradox of mucosal drug delivery. Yes, the physical distance the drug has to travel is drastically shorter, so based strictly on Fick's equation, the rate of diffusion should skyrocket. But you're forgetting the environment.
What do you mean?
This tissue isn't just a thinner version of a healthy wall, it is severely dysfunctional.
But if the drug is getting across the barrier faster, why does the cellular dysfunction mess up the delivery?
Because it disrupts the highly coordinated mechanics of transport. Normally, there's a delicate dance between the transcellular route going through the cell and the paracellular route going between the cells. For example, there's a biological phenomenon called solvent drag.
Solvent drag.
Yeah, usually when a healthy cell actively transports nutrients through its interior, it creates a localized current. This osmotic gradient physically pulls water through the tight junctions between the cells, dragging other useful molecules along with it.
Ah, so the ink soaking through the sponge is actually creating a current that pulls water through the cracks next to it. They work together.
Precisely. But when the cells atrophy and shrink, that architectural coordination collapses. The cell forgets how to actively transport, so the current stops. The barrier entirely loses its ability to be selective. You aren't just dealing with a shorter hallway, you're dealing with a hallway where the walls are crumbling and the floor is caving in.
Wow. Which brings us to the core focus of this deep dive.
Yeah.
How does this active epithelial atrophy dictate transmucosal drug permeability? It creates an incredibly chaotic, unpredictable environment for medical treatments.
It becomes a perfect storm of physics colliding with broken biology. On one side, Fick's law is hyperactivated because the diffusion path length, that thickness denominator in the equation, is drastically reduced. Drugs that are designed to take hours to slowly permeate might rush across the barrier in mere minutes.
But at the exact same time, the biological gates regulating what should go through are broken. The sources mention that in these diseased atrophic states, the pericellular leak pathway or microscopic pulley system is often forced wide open.
Yes.
And studies show that this leak pathway's permeability can increase entirely independently of the selective pore pathway.
So you have a thinner physical barrier combined with large, uncontrolled physical cracks between the cells. The floodgates are wide open. To truly understand the stakes of this, let's look at a powerful clinical example from our sources. Genitourinary syndrome of menopause, or GSM, which involves severe vaginal atrophy.
This example really crystallizes everything we've been talking about.
It does. As a woman enters menopause, the natural decline in estrogen leads to a profound loss of structural proteins in the vaginal mucosa. The collagen fibers, which provide structural support, become fragmented. Elastin degrades. The tissue becomes incredibly thin, losing its mechanical resilience.
And crucially, the sources note that this decline in estrogen also massively reduces blood flow to the submucosa, that underlying highway of blood vessels we talked about earlier.
That's the kicker.
Yeah, so the tissue not only becomes paper thin, but it also loses its transudate. Now, transudate is just the natural fluid or lubrication that gets pushed out of the tissue by healthy blood pressure. Without blood flow, the transudate just dries up.
Now, put yourself in the shoes of a doctor prescribing a mucosal medication to this patient. Perhaps it's a topical hormone cream or a local therapeutic gel. If you base the dosage of that cream on a model of healthy, thick, well-vascularized tissue, what actually happens when it hits this atrophic environment?
Let's walk through it. The cream hits the tissue. Because the cellular wall is paper thin, Fick's law takes over, and the drug rushes through the cells incredibly fast.
Too fast.
Way too fast. At the same time, because the tissue is structurally broken, the leak pathways are wide open, letting even more of the drug pour through the cracks. But here's the terrifying part. Because of the reduced blood flow we just talked about, the submucosa doesn't have enough functioning blood vessels to safely sweep that massive influx of drug away into the wider circulatory system.
The highway is shut down.
Exactly. So the drug just pools locally in high, potentially toxic concentrations, or randomly spikes into the bloodstream in chaotic bursts, rather than the slow, steady release the drug designers intended. Applying a drug to atrophied tissue isn't just delivering it faster, it's delivering it into a broken system.
If we connect all of this to the bigger picture, we have to fundamentally change how we view our cellular linings. We have to stop thinking of epithelial thickness as just a passive physical wall. It is an active, living, constantly changing dimension of human health. The physical microscopic height of those cells directly dictates whether a drug acts as a carefully measured therapeutic or a sudden flood into the body. The biology dictates the physics.
It is incredible to think about the journey we just took today. We started with Adolf Fick writing out strict mathematical equations of diffusion in 1855. Traveled down into the microscopic sponges and pulley systems of our internal cells, and finally arrived at the very real clinical realities of shrinking tissues in diseases like celiac or conditions like menopause.
It forces the medical community to confront a difficult reality. The healthy, robust body you test a pharmaceutical drug on in a clinical trial might act completely differently than the sick, atrophied body you are eventually treating in the real world. The landscape shifts.
And that shifting landscape is exactly why things in medicine can be so muddy, so far removed from the clean, comforting precision of a broken bone on an X-ray. When the tissue itself changes shape, it rewrites the rules of physics, and our medical treatments have to adapt to that new reality.
Which leaves us with a rather profound and somewhat unsettling question to consider based on everything in these sources.
What's that?
If epithelial cell thickness directly dictates how fast and how aggressively a drug permeates the body, and we know as a biological fact that cellular atrophy naturally occurs across all of our mucosal tissues as we age,
Right.
how many standard dosages of common mucosal medications are currently overwhelming the systems of the elderly, simply because their cellular walls are microscopic fractions of a millimeter thinner than the healthy young adults those drugs were originally tested on.
Wow. That is a wild, incredibly important thought to leave on. The
Mhm.
dosage printed on the bottle might be exactly right, but the cellular wall it's hitting is just too thin. Thank you for joining us on this deep dive.
Sure.
Keep questioning the world around you, keep looking closely at the tiny mechanisms we take for granted, and we will catch you next time.